Good evening, everyone. I'd like to acknowledge the local custodians of the land in which we meet this evening and on elders past, present and emerging. I'm Mel Wilkinson from the Hunter New England Central Coast Primary Health Network. Welcome. Just some housekeeping. We have a poll tonight at the end of the session to record your data for the evaluation. That data is really important to us and we use that for future event planning. So please complete that. It only takes a couple of minutes. We are being recorded and a copy of this will be available in the Education Library. And questions, I strongly encourage you to please pop those questions into the questions box, and we'll save a time after Eve's presentation to check that, to see if there's anything in there, and that's your chance to ask those questions. So great to have an antenatal topic tonight. And just a reminder that next Wednesday night, if you haven't already registered for the medications in antenatal care, that's also happening, and you can register via our website as well. So it gives me great pleasure now. I'll hand over to Dr. Natalie Cromer, who's going to do the iron management in maternity patients. Over to you. Thank you.
Okay, so hi everybody. Thanks for having me on in your network. So I'm a haematologist and obstetric physician, and I've been asked to talk about iron management in maternity patients, but I thought that I would actually just start with going through interpretation of iron studies in general, because I think that's a really good place to start, and then you can manage all patients, including maternity patients, a lot better. I should also say that I find the whole idea of talking through a webinar to be a little bit off-putting. I'm much more used to an interactive session, so I'm just going to have conversations with myself going through. A lot of my slides in the beginning was supposed to be a question and answer format, so I'll talk about it myself. So here I've got some iron studies, and as you can see, the ferritin is very high. So I normally ask people what they think about all this, and we get a range of answers, but often a lot of people talk about iron overload. But as you can see, when I add on some extra iron studies, the remainder of the iron studies, particularly the transferrin saturation, is normal. So this is actually not iron overload. This is hyperferritinemia from another cause. This is a picture of hyperferritinemia from iron overload. Even though the ferritin isn't nearly as high as what you saw on the previous slide, that transferrin saturation being up at 80% is showing us that it's true iron overload. This looks like it's some normal iron studies. The ferritin is normal, it's 53, so most people would probably think that this person's iron replete. But then when we add in the transferrin saturation, we can see that that's low, so that's indicating to us that there might be some early iron deficiency there. This one is hopefully pretty easy, and everyone can recognise that that is stock standard iron deficiency. So that was just a few results to warm your brain up, but this is essentially what I'm going to talk about. How do we interpret iron studies? What do we do when the ferritin is low? And then just a little bit very briefly about the ferritin being high, because that is not such an impact in pregnancy. Okay, really complicated slide here. Even I think it's complicated. You don't need to understand everything in this slide, but I'm going to simplify it a lot for you. So if we just break it down, iron is absorbed through the enterocytes, right, the lining in the gut wall, and it's absorbed into the blood vessel, and then it's carried around, and there's a whole bunch of feedback mechanisms that helps our body regulate iron. Once iron is absorbed, we have got no way of excreting it. So the only way we lose it is through blood loss. If we have too much iron on board, then that feedback comes at the gut wall interface when we absorb it. So I'm going to simplify that a lot for you by introducing you to what I consider to be the two key players in iron metabolism. And this is how I like to think of them, because it makes it so much simpler. So we've got transferrin, which I like to think of as the buses, which carries your iron around your body, and hepcidin, which I like to think of as the bouncer, which regulates how much iron is absorbed at the gut wall. So now I've gone back to that original slide. I've hopefully simplified it. So when iron is absorbed, it gets carried around on these buses called transferrin. And ideally, we want our buses to be about half full so that there is room for iron to get on and off. Okay, if our buses are less than half full or quite empty, around 10% full, then we just don't have enough iron around. If our buses are too full, 60, 70, 80%, then we've got too much iron around. So the transferrin carries the iron around. That's detected by the liver. In response to an iron load, the liver then releases hepcidin, the bouncer. That feeds back to the gut and says, no, thank you, gut. I don't need any more iron. I've had enough iron. And this is going to be really important when we come to talk about oral dosing in pregnancy or in any case. So now I'm going to take you through the iron studies and how do we interpret them in context. So ferritin. Most people think of as ferritin as a marker of our iron stores, and it is a marker of our iron stores, but it's not only iron. Okay, ferritin, as you can see, is that spherical protein there, and in the middle of it is a small amount of iron, but the actual ferritin is just the shell or the core, and the iron is contained inside. So you can have an increase in the outer core, being the ferritin, without having an increase in your iron. Okay, when iron is deposited in our organs, it's not deposited as ferritin, it's deposited as hemosiderin. Ferritin is the storage format, and it's also an acute phase reactant. So it's released by the liver in response to inflammation. So keep in mind that a high ferritin doesn't always mean high iron. The next thing that I'm going to talk about in iron studies is the serum iron. So this is a really dynamic result. I've got the picture of the steak there because it very much reflects our recent dietary intake. Ideally, we would want to interpret iron studies fasting, but that's not always done. We use the serum iron to calculate the transferrin saturation, but my general advice to you is just ignore the serum iron. It doesn't really contain a lot of value on its own. Okay, the next thing that gets reported is the transferrin, which, as you know, I like to think of as the buses. So that measures your availability to transport your iron around your body. Some labs will also report the total iron binding concentration, which basically gives you the same amount of information, how many seats are available in our buses. That is calculated, whereas transferrin is measured directly, but it really gives you the same information. So transferrin will go up in iron deficiency. Again, that's our body's response to saying, we don't have enough iron, send out more buses. And unlike ferritin, which I mentioned is an acute phase reactant, transferrin is a negative acute phase reactant. So it goes down in inflammation. And so we've got less capacity to transport iron around our body in inflammation. Okay, the transferrin is then used to calculate what I think is the most helpful part of the iron studies, which is the transferrin saturation. And that is literally how full are your buses. It measures the ratio of iron to transferrin. Now, I've just told you a few slides ago that iron is not a really very good test and you should ignore it. And now we're using it to calculate this. So transferrin saturation is also affected by recent intake. So you can get a transferrin saturation that is a little bit high in a non-fasting patient, but if it's low, it's very reliable as a marker of inadequate iron stores. Okay, a little bit more about hepcidin. So hepcidin is what I like to think of as the bouncer. You don't get it as a test result on your iron studies, of course. It's not something that we can test for, but if you can think of it in the background as the mechanism of what's happening here, it'll help you interpret things and manage patients appropriately. So hepcidin is reduced in response to iron deficiency. That makes sense because we want to absorb as much iron as we can from the gut wall. It's also reduced in pregnancy, which also makes sense because in pregnancy we need a lot of iron, so we really want to be absorbing a lot. Critically, it's increased following an iron load. So when you have something that has a lot of iron in it, whether it is a steak or an iron supplement, then the transferrin transports that to the liver sends out hepcidin comes out and says, no thanks, I've had enough iron. So then the next bit of iron that you eat will not be readily absorbed. And I'm going to come back to that when I talk about the dosing for oral iron. Hepcidin is also increased in inflammation, so it is an acute phase reactant, and that significantly contributes to anemia of chronic disease. So the inflammation leads to an increase in hepcidin, which means even if we're eating iron, it's not being well absorbed. And as I mentioned earlier, it's also not being well transported around the body. Okay, so then moving on to iron deficiency. Iron deficiency is pretty easy to diagnose when the ferritin is low. There's no question about that. But we can also have iron deficiency when the ferritin is normal and the transferrin saturation is low. So this is thought of as functional iron deficiency or iron-restricted erythropoiesis. And keep in mind that abnormal iron studies will always precede the anemia. So it's only when we get severe iron deficiency that we start seeing changes on the blood count. We start with the microcytosis. So you can see in the picture there of the blood film, the cells are smaller than we might expect. You can see some platelets there for comparison, and the red cells are almost the same size as the platelets. They get smaller, they're paler, and only then do we develop anemia. So moving on to pregnancy now. Of course, we all know that we've got higher iron requirements in pregnancy. So this is for both the erythropoietic reasons of the mother and the fetus. So not only is the mother making her own red blood cells, and we know how much cardiac or blood volume increases in pregnancy, she's also making blood cells for the fetus. But it's also important for development of the placenta and really has a lot of critical roles in a lot of metabolic activities. So the iron demands throughout pregnancy are about 1 gram, which is for women who are going in iron replete. And of course, if a woman goes into pregnancy iron deficient, she's going to have higher iron needs. But it's not uniform throughout pregnancy. There's much higher demands in the 3rd trimester as compared to the 1st trimester. So won't delve into this too much. I think if you think about using a cutoff of a ferritin of less than 30 at the bottom, not greater than 30, less than 30 in pregnancy, you'll be far less likely to miss women with iron deficiency. So now I'm going to speak a little bit about why iron is important in pregnancy. So why do we even care about this? So the first thing is the erythropoietic effects, which is what most people think about when we think about iron. So if the woman is iron deficient, she can become anemic, which can lead to cardiac failure for the mother. It can also lead to fetal anemia. Anemic women have got a higher risk of postpartum hemorrhage, and then if they do bleed, they have a higher likelihood of requiring transfusion of blood products because they're starting from a lower baseline. And of course, we try and avoid transfusion where at all possible because of the risk of a transfusion reaction and also for antibody sensitization for a future pregnancy. It's also important to think about the fetus because they can become iron deficient as well. And we know that neonates born to iron deficient mothers can have iron deficiency. And the critical threshold is maternal ferritin of about 10 to 14 micrograms per litre. And I'm sure you have all seen plenty of pregnant women with ferritins less than that. So once we obviously know about the erythropoietic effects of iron, but it's also important to think about the non-erythropoietic roles of iron. So iron is important for a real number of metabolic processes, and critically in the central nervous system, it's really important for cognitive function. And this is actually true of both the mother and the neonate. So now I'm talking about iron deficiency even without anemia, so taking the erythropoietic effects out of it. But in pregnancy and the postpartum period, iron deficiency without anemia has been shown to cause a lower birth weight. It also causes impaired neurocognitive function, including poor memory and slower processing in both the mothers and the infants. And there have been some really long follow-up studies. There was one very large one in Brazil, I think, which followed the infants born to iron deficient mothers out to 19 years. So when those babies were all the way up to 19, the babies who were born iron deficient, even though their iron deficiency was corrected, so they were no longer iron deficient in childhood and adulthood, actually had long-term neurocognitive impacts compared to babies who were not born iron deficient. So this is all about setting people up for life. It's also got associations with mood, and postpartum iron deficiency is associated with postpartum depression. And there have been some interesting studies showing that when women's iron deficiency is treated, their postpartum depression also improves. And it's also been shown in studies looking at mother-infant interactions that there are more meaningful interactions in iron replete mothers compared to iron deficient mothers. I'm not going to go through all of those studies. There are a lot, but the point that I want to make is in all of these studies, they normally break the women up into 3 groups, which is iron sufficiency, meaning she's got enough iron, versus iron deficiency without anemia, versus iron deficiency anemia. So even though for the erythropoietic side of things, we're obviously concerned about the anemia, for the other metabolic features, the breakpoint is actually iron deficiency versus iron sufficiency rather than anemia. So it's important to replace iron even before a woman is anemic because it sets her and her baby up for much better outcomes. So how are we going to do it? Now we get to the real crux of the issue. So the way we're going to do it is just give them more iron. Iron is very simply a balance of input versus output or needs, right? We don't have losses like we do for other things. So in pregnancy, the demands are high. Most women can't keep up with it from their diet. Oral iron is always first line, okay? I used to work with a consultant who was very facetious, and he used to say, If someone asked and said, could someone take oral iron, he would say, do they have a mouth? The only contraindication to oral iron is not having a mouth. Now, I don't go quite that extreme, but I do think that oral iron should always be first line. There are a lot of different supplements out there, and they all contain varying amounts of iron, as you can see there. On the left, I've also put the cost there because a lot of people don't think about that. Ferrograde C is very popular. Most people seem to be on it, but it's about 4 times as expensive as Ferro F-Tab, which contains the same amount of iron. Some of them are marketed as having less gastrointestinal side effects. I'm not really sure if that's real. Iron itself is constipating. It's a feature of the iron. When you're prescribing iron, you want to have it a minimum of 60 milligrams of elemental iron per day. So there's some supposed iron supplements that contain really minuscule amounts of iron. So make sure if a patient's on something that you're not familiar with, you're always checking the amount of elemental iron in there. A lot of the pregnancy multivitamins contain, well, they all contain iron of varying amounts. Some of them contain a decent amount. For example, Elevate contains 60 milligrams of elemental iron, which sounds like a really good amount, but it also contains calcium, which binds the iron. So it's really important when we prescribe iron that we counsel women on how to take it. And I think a lot of the sort of failure of oral iron is because women haven't been adequately counselled when it's prescribed. So every time you're prescribing iron, you need to tell the women, number one, how we take it. So we take it ideally on an empty stomach, but with something acidic. And that's why the Ferrograde C is good, because it's got that vitamin C to help with the acidity, which helps with the iron absorption. They need to take it away from their other supplements, particularly things like calcium. A lot of pregnant women might be on Caltrate because that will bind it. And we need to warn them about the constipation. Now, I might talk about the dosing a little bit further. I'm not sure if I've got some slides on it, otherwise I'll come back to it. I've pretty much mentioned that about the different dosage in different supplements. Okay, iron is constipating. If a woman tells you that she's found an iron supplement that isn't constipating, check the ingredients list because it probably doesn't contain very much iron. So every time you're prescribing iron, you need to warn the women. And as you know, pregnancy itself is very constipating. So I normally talk to them about Metamucil and Coloxil without Senna, both of which are safe in pregnancy. Okay, so how often do we give oral iron? So now I'm coming back to our friend hepcidin. Remember, when you get an iron load, the liver releases hepcidin, and then you're not absorbing iron so effectively. So now the current practice outside of pregnancy, unless somebody's really profoundly iron deficient, is to recommend that they take iron supplementation alternate days. That reduces the amount of constipation, and actually the actual absorption from the iron is not quite as good, but almost as good as daily dosing. They've done studies outside of pregnancy, and the amount of iron absorbed is the same when you do daily versus alternate day dosing for the same number of tablets taken. So you can appreciate that in pregnancy, when time is finite, it takes twice as long to take the same number of tablets alternate days. So sometimes, often I might recommend that iron is taken daily in pregnancy, but it would be reasonable for someone who's not that iron deficient or certainly not anemic to recommend they start alternate days, but definitely not BD. Okay, there's no point prescribing a BD. You're just giving the woman constipation. She's not going to absorb it anymore. Okay, so now I'm going to move on to intravenous iron. It has a role, but the role is second line. It's after they have tried and failed oral iron for a number of reasons, and it's safe in the second and third trimester. So generally for intravenous iron, we would expect that the woman should be anemic, not just iron deficient, in order to justify giving her IV iron. And she has to have either failed to respond to oral iron, be intolerant of oral iron, or you need to get a really quick increase in her hemoglobin because she's delivering soon. There might be some other groups that we would consider IV iron as a first line basis, but I wouldn't think of it as a rule of thumb. So this is a study looking at the amount of iron this is in pregnancy, from intravenous iron compared to oral iron. And you can see in that graph on the right that after a 12-week period, they basically end up at the same spot. So it's not like intravenous iron is so much better. The real benefit of it is for absorption in a woman who can't absorb iron, or if you need a really quick increase in the hemoglobin. Okay, there are 4 parenteral iron preparations in Australia, but really only 2 that we would use routinely, which is ferric carboxymaltose, marketed as Ferinject, and ferric derisomaltose, which is marketed as Monifer. And these are all approved on the TGA for iron deficiency, where oral administration is ineffective or contraindicated, or where there is a need to deliver iron rapidly, which is exactly what I was saying before. It's your second line therapy. I'll go quickly through the adverse reactions. I'm just a little bit conscious of time. Hypersensitivity is a class effect of all iron. However, we're seeing it much less now with the newer preparations. It was much more common with iron dextran, which we don't use anymore in Australia. The TGA has recently released an update warning about the risk of fetal bradycardia, which is thought to be a reaction to hypersensitivity, which could compromise maternal oxygenation, lead to fetal hypoxia, and then subsequently fetal bradycardia. So at my institution now, we're recommending that all women are having CTG monitoring whilst they're having IV iron. There's also been a TGA warning for this thing called Kuhn syndrome, which is probably pretty rare, but there's been a few reports of it, otherwise known as acute allergic coronary syndrome. It's essentially vasospasm, which is mediated by the inflammatory mediators, which might occur during a hypersensitivity reaction. Low phosphate is also pretty rare. It's an idiosyncratic reaction to ferric carboxymaltose. In most people, it is very mild, and they might get a hypophosphatemia but no symptoms. Only very rarely can it be a severe hypophosphatemia. The nadir is 2 weeks after the iron infusion. I generally don't worry about this unless you're giving repeated iron infusions, in which case I'd be checking the phosphate before your before the second infusion. Although I should mention that the recommended combined total dose of ferric carboxymaltose in pregnancy is 1.5 grams. So if you thought a woman needed more than that, then I would be recommending you discuss that with either an obstetrician or a hematologist. And of course, you're all probably familiar with skin discoloration or iatrogenic cutaneous siderosis. Unfortunately, this is not reversible. It's one of the features we used to see in people who had hemochromatosis, where the iron deposits in the skin. It's really to do with the administration of the iron. So we want to make sure that it's going through a large bore cannula. The cannula is flushing really well. You're not using a site that's prone to flexing or kinking. If you see it happen, you want to stop the infusion immediately. It's not reversible. There's been some results, some reasonable results with laser trying to reverse it, but ideally we just want to avoid it from happening. And this is just a very large audit from America looking at their adverse events in their iron infusions. And I guess in summary, the adverse events are really pretty low. So we do consider it to be a fairly safe procedure, but there are these risks associated with it. So I always think, if, hopefully no one does have an adverse event, but if they do, you have to have a good justification for why you gave them IV iron in the first place. Look, I probably won't talk about a high ferritin now, just in the interest of time, and it's not so relevant for pregnancy. So I'll probably leave it there and open it up to questions, but if there's any time at the end or if anyone's interested, I'm happy to talk a little bit more.
Okay, is that the end of your session, Natalie?
Yeah, look, I think I'll just leave it there in the interest of time because I don't want to take up all the time for Penelope. So, yeah.
Okay. I've just checked the questions box and none have come through yet, but if anyone has any questions, could you please pop them in there? We will check them again at the end of Penelope's session as well. So thank you very much, Natalie. We're going to hand over now to Dr. Penelope Forthingham and for her presentation. And just a reminder that a poll will pop up at the end of the session. If we can get you to please complete that. That's the data that we base future planning for education on. So thank you. And a reminder once again, just pop those questions into the questions box. Thank you.
All right.
Great.
So thank
Yep.
Looks
good.
Good. Yep. Yeah.
Yep.
So thank you. If there's any trouble with my sound, as I said, people please do let me know or pop something in the chat, because I think the weather is changing and sometimes that makes internet connections not behave in the way we would like them to. So I just would like as well to acknowledge the traditional custodians of country and all the areas that we're currently dialing in for in New South Wales, their connection to land, country and community, and acknowledge any Aboriginal or Torres Strait Islanders here today listening to our talks. And I'd also like to say thank you for the people that have tuned in today on the eve of a public holiday to still have some education. So I'm going to be talking sequentially through pregnancy with the different forms of ultrasound. Some of the content I appreciate that will be familiar to you, but hopefully it's helpful and there may be some points in there that help you in your practice in an ongoing manner. So thinking of the first scan in pregnancy that women will experience, normally we call that colloquially the dating ultrasound, which is really an ultrasound which is assessing the viability of that pregnancy. And viability in this context for us means that it's the presence of an embryo with a cardiac activity at the time of that examination. So we normally would perform it greater than or equal to 6 weeks because that is the time when we expect to see a fetal heart rate present. When you look at when we may first see cardiac activity in embryo, that's normally at a fetal pole size of 1 to 2 millimeters. And the fetal pole increases 1 millimeter a day. So when they've done studies longitudinally, they've said, well, actually 5 to 10% of viable embryos don't have a fetal heart rate until that fetal pole is 2 to 4 millimeters, which is greater than that 6-week mark, which is why we're obviously conservative with thinking about when a viability is not present for a pregnancy. Obviously, this scan is done transabdominally and transvaginally. It is important, obviously, that we do it both ways. Unfortunately, with the changing body habitus of women in our community, transabdominal scanning is becoming less reliable. We really need to ensure that transvaginal scanning is done at all ultrasounds because it gives us further information either about early pregnancy or later on with things such as our morphology scan, thinking about cervical insufficiency. The order that we would see things doesn't change in a dating ultrasound. It's based on the embryological development. So the first thing we always see is a gestational sac, which is reflecting intrauterine pregnancy around the 3 to 4-ish week mark. You can see something which is a confounder, which is called a pseudosac, which I've got a slide on to show you, which is actually something which reflects an ectopic pregnancy and it's diagnosed due to its position being midline rather than eccentric. Mean sac diameter is the measurement that you all know will be reported. That's giving us that size of the actual sac when we're looking at it. And as you know, our cutoff for a non-continuing pregnancy is 25 millimeters now for a mean sac diameter, which was changed a few years ago from 20 millimeters. This measurement is more variable for gestations, hence the change to the upper limit to the diagnostic criteria of 20 to 25 millimeters instead. We then see the next structure, which is the yolk sac, which embryologically is the gut of the baby, which then will be reabsorbed into the abdominal cavity, and then the anterior abdominal wall closes. So when that doesn't occur appropriately, that leads to a pregnancy complication called omphalocele, which I'll show you a picture of later. Then the fetal pole, which we also call later in pregnancy the crown rump length, when we actually have a distinguishable head and bottom of the baby to be able to measure. So just a quick picture to show you the reason we have those two terms. So when you look at the picture on the left-hand side, there's a teardrop shaped structure, which is the endometrial thickening there. You have a midline echo in the middle, and you can see the location of that circle is not directly in line with that midline echo. It's off to one side or eccentric. So that's reflecting a viable intrauterine or potentially intrauterine pregnancy, which is viable. Whereas with an ectopic pregnancy, you still do get fluid inside the uterus, which accumulates, but it will be in the midline rather than eccentric. So it's one of the markers from an ultrasound perspective that we use when we're thinking about, could this be an ectopic pregnancy? In the context of things such as a pregnancy of unknown location, where we don't necessarily see an ectopic pregnancy or an intrauterine pregnancy. And these are some pictures from left to right, just reflecting the structures that I have spoken about. And you can see at the top when we expect to see them with the number of days/weeks from the LMP. So on the left, it's the picture that we just showed previously, that gestational sac. The middle picture is showing you a yolk sac inside the uterus, and those, as you can see on the left-hand side there, that's actually just a flattened ovary, I think, potentially when you're looking at it. So that's not the uterus. And then on the right-hand side, there's a measurement of fetal pole there, where you can see the yolk sac is still present and hasn't been reabsorbed into the abdominal cavity of the baby yet. And I've got all the references there as well. So if people want to go and read through the material and look at these pictures, they can in their own time. So the next scan that is important is that 12-week scan, and I've called this a structural scan because many of the people that you'll be seeing in primary care are now having an NIPT done, so they don't go through that formal nuchal translucency scan which we used to do. But obviously it's still important that we still structurally assess the baby for congenital changes, because the NIPT doesn't give us information on those things. And the worst case scenario is a woman that has a low risk NIPT test performed but does not have a structural scan, and then waits till 18 to 20 weeks and finds out that there is a congenital change potentially that makes her baby not compatible with life. So we still would offer this at the same time frame that we offer a nuchal translucency. So that's between 11 and 13 plus 6 weeks, or 45 to 84 millimeter crown rump length. And the reason that time was originally chosen for a nuchal translucency is because it's where the fetal size is adequate for us to be able to diagnose most major fetal anomalies that may mean that people may consider not continuing a pregnancy. Equally, the evidence base we have for nuchal thickness is optimal at this point in time. As you can see, I've got the reference there from the ISIOG guidelines for the picture as well, and further information. So the combined first trimester screening test, I know that you're all familiar with this. It's a test which takes into account multiple factors, so some demographic factors of the woman, some fetal factors, so the measurement of the fetal size, nuchal translucency, presence or absence of the fetal nasal bone, then thinking about some pathological tests as well, so thinking about the maternal blood test with PAP-A and the free beta-HCG. So obviously they go into an algorithm and then they give us a risk for the presence of trisomy 21, 13 and 18 in the pregnancy. As you will know, PAP-A is also explored as a marker for other issues in pregnancy related to things such as placental insufficiency. So it also is used as a marker of intrauterine growth restriction, particularly women of increased age, and other medical conditions such as preeclampsia and complications in pregnancy as well. And if people did wish to further their learning on this, I've put the link there to an online learning program as well if you wish to do some more education. The combined first trimester screening test is sensitive and specific. About 2 to 3% probably give an increased risk result. And I've put there as well that in New South Wales health guidelines say our cutoff is 1 in 300 for increased risk. You may see that as different dependent upon the ultrasound facilities that women go to for their testing to be done. So just to remind you as well that this is what we're actually looking at. There's obviously strict ultrasound criteria and accreditation for people performing these ultrasounds, but what we're looking for is at the top of the picture, the nasal bone, which is present, which is, you should see what looks like an equals sign, which so you're seeing the skin line and then the nasal bone. And then at the bottom, you're seeing the nuchal thickness there, not to be confused with the bright line here, which is the amnion. And the reason that this scan is so important at 12 weeks is because we can pick up, as I said, structural changes which may change people's pregnancy wishes or indicate that further diagnostic testing should be done. So at the top left, you can see a cystic hygroma, which is a significantly increased nuchal thickness. And this may be associated with conditions such as chromosomal anomalies with trisomy 13, 18, 21, associated with Turner's syndrome, cardiac anomalies in the baby. So obviously it's important if we find that then we think about further investigations. The middle picture is a picture of an omphalocele. So that yolk sac that we were talking about in that previous slide is the round structure here on the right-hand side. And then the structure on the left is the abdomen of the baby where there is a defect there. So the abdominal anterior abdominal wall hasn't closed, and that baby will not have that happen throughout the rest of the pregnancy if it hasn't happened in the embryological period. And then obviously things that are not compatible with life. So the baby in the top right has acrania. So obviously that's important to be able to diagnose, counsel women, and then talk to them about their pregnancy options. So preeclampsia screening is something which is obviously really almost routine that you'll be seeing done when people are going for their 12-week ultrasounds now. What it is a Doppler examination of the uterine arteries. It's best performed at 11 to 13 plus 6 weeks, as I said before, transabdominal and transvaginal. There's two markers that you tend to see reported when we're talking about this. One is talking about bilateral notching of the uterine arteries. This is associated with an increased risk of preeclampsia, but it's quite low sensitivity. Up to 50% of normal pregnancies may have this. So it's not the one that we tend to think about as more reliable when we want to diagnose risk for preeclampsia. Actually, I should use the wrong term there. When we're screening for risk for preeclampsia, because this is a screening test. What is more reliable is pulsatility index. And so when you have an increased mean PI greater than the 95th centile, then that is more sensitive for preeclampsia that may require delivery in the preterm stages. So that potentially gives you the option of appropriate referral for your women. Thinking again, if you haven't at that point in time, about aspirin for prevention of preeclampsia, and also thinking about obviously preparing a woman's expectation for the progress in her pregnancy. So NIPT you'll all be familiar with. Again, another screening test that as I'm sure you understand the mechanism in which I don't want to go through it, but it is a test which is obviously a maternal blood sample is drawn, and from that we extract fetal cells, cell-free fetal DNA, and from that we look at the pattern of volume of the DNA that we have and see does that reflect what we would expect from the picture of maternal and fetal genetic material. And obviously if you get areas where you have increased genetic material which are flagged, then that potentially means there's a chromosomal anomaly in the baby. It is obviously very sensitive and specific for the three main chromosomal changes that we think about, so trisomy 13, 18 and 21. It can also look up sex chromosome changes, so things such as Turner syndrome. And now obviously it is less expensive, even though there's still a cost to it. It's more obtainable for women, and their results come back in a time frame which is acceptable in pregnancy. It is important to note that obviously there are test failures that occur in sort of really up to 10% of samples, because there is insufficient fetal DNA to be able to actually perform the test accurately. And we know that that is more common in women with a BMI over 30. It also is related as well potentially to placental mosaicism. So you may have a placenta plus or minus fetus that has two different DNA pictures in it, which means that the signal can't be interpreted. Undiagnosed maternal chromosomal abnormalities, maternal malignancy as well will cause you to have a test which cannot be interpreted. Obviously, those things are very rare. So the first thing you think about is, well, you know, unlikely it's going to be a maternal malignancy. Are there other reasons why this could be a false positive? And then you think about offering alternative screening to that woman, or potentially repeating the test if that has been indicated as an option. And the company will normally tell you if they think that the test should be redone. So this is one company. I'm not advertising any particular company, but this is just a nice table. So you can see obviously that we routinely do trisomy 13, 18 and 21, and then there's an option for other tests to be done as well. And obviously that means that the counselling that women need to have increases prior to going and having these tests, because one of the most important things for any woman having a screening test is she understands it is a screening test. She understands what the results could be for this and what it would mean for her pregnancy if she comes back as positive or high risk for a condition on these screening tests. And it does become quite complicated because we're educating people on basic genetics at a time when they're quite emotional. And it's a balance, obviously, with your rapport and relationship with the patient, with the information that you give them at each point in time. The other thing just to have in the back of our minds is that sensitivity and specificity does slightly differ for the different conditions. So not as much as you would be concerned about for doing the test when you're thinking about trisomy 13, 18 and 21, things like, but when you think about things like 22q, that's obviously associated with significant cardiac problems, neonatal epilepsy, that's got lower sensitivity. So if that's something that someone is particularly concerned about, then you obviously would need to express that to them. And the other thing to make sure that you think about as well is obviously what the maternal background risk of any of these conditions is, or the population prevalence, because we know that when we look at tests, that as if you decrease your population prevalence, then that decreases your positive predictive value, increases your negative predictive value. So potentially you need to be thinking about that if you're going to be doing these tests in a age range or population that has less prevalence. So thinking about it, looking in really young people, it's potentially slightly less accurate than in the people that are having children at increasing ages. So second trimester screening, I'm just briefly going to mention, I don't want to go too long with my going through these slides, just because it's something that you probably aren't seeing at all anymore. So just to remind you about it. So previously before NIPT, then this would be what we would do if people had missed that 12-week nuchal translucency screening window. So this is performed 15 to 20 weeks, best at 16 to 18 weeks, the combination of alpha fetal protein, beta-HCG, estriol and inhibin. It isn't that sensitive or specific, which is why we don't tend to do it. And equally, obviously, it's not an alternative to a first trimester screening test. So if someone's had their first trimester screening, we don't do this as well and take the lowest risk result. Alpha fetal protein can be useful for, particularly for things like omphalocele, it would be increased, so that can be helpful in combination with ultrasound. But the majority of people who present at 15 weeks of pregnancy having not had any screening, we'd probably be offering NIPT to them now if they can afford to have that test done. Obviously, you can think about the morphology ultrasound as a screening test because it will pick up structural changes in babies, but it's not recommended for things such as trisomy 21 because you may have no obvious structural changes in a baby that has a chromosomal condition such as trisomy 21. When we think about second trimester, around 75% of babies with trisomy 21, so you can see that's significantly lower than the other tests we've been speaking about. And for women over age of 40, then it's obviously a test that we would be careful about doing because if 1 in 2 of them has an increased risk result, then that means that they're going to be subject to potentially invasive procedures that may have complications for their pregnancies. So chorionic sampling, just a quick run through diagnostic testing. So I know that you will be referring women to ultrasound places for this, potentially to maternal fetal medicine as well. So we do it after 11 weeks of pregnancy, and being able to perform a chorionic villus sample depends upon the placental position, whether we can actually access it based on the maternal habitus as well. So as you will all understand, it's done transabdominally with a fine needle, which goes through the abdomen into the placenta under ultrasound guidance. And then we agitate the needle to be able to extract some of that placental tissue. And you do get some fluid that is a bit of a red color coming out like that. In that solution, we'll obviously have placental tissue, so that can then be grown, genetic material will be extracted, and we tend to get a fast result, the FISH, fluorescent in situ hybridization, back within 24 hours. And that will give you an indication that there is a genetic change in that baby, but it's not confirmatory till we get the full genetic profile back. It is a procedure that people can obviously have complications in it, and the quoted miscarriage risk we talk about is 1%, but this will change in different sites So when people go to a specific ultrasound facility, they'll be quoted the rate for that facility for the risk in that procedure. The concern with CVS, the difficulty with this test, is that we are taking placental tissue for our genetic sample. So if placental mosaicism is present, then we don't get a true result for the genetics of that child. So that's, in that case, then we'd be thinking about then having to do an amniocentesis as well to be able to confirm the genetic profile of that baby in the context where we're not 100% sure. It would depend on conversations with the parent. Obviously, if you'd already diagnosed, a potential lethal anomaly in the baby, then it would be, well, how much information do we need to know about the genetics of this pregnancy for future pregnancies potentially, rather than that pregnancy itself, which may not continue, dependent on the wishes of the parents at that point in time. We can use it for conditions that you may not think about, so fetal genetic disorders like muscular dystrophy, and that's important because obviously those are things that people would want to diagnose as well, which may not be seen on ultrasound. And when we talk about a failure rate, we're thinking about where we're unable to get sufficient sample, unable to get sufficient genetic material to be able to interpret what the profile of that baby is. So quick picture, that's just showing you placenta, which is there, and you've got here coming through, there's a needle tip there with a hyperechoic part that you can see. There's that needle. And don't have too much more to go. So amniocentesis, 15 weeks onwards, same idea, going into the amniotic fluid this time. So we're obviously getting a clear/yellowish fluid coming out, correlating with fetal urine, which is what the majority of the amniotic fluid is. This is done transabdominally. It's done after 15 weeks because we want to make sure the amnion and chorion are fused to the myometrium. We can get the results in the same time frame as with a CVS. Because it's later in pregnancy, then the risk of miscarriage is less. So we talk about 0.5% or 1 in 200. And obviously, because it is not taking placental cells, then we don't have that risk of mosaicism. So that's why we talk about that as the gold standard test for fetal chromosomal analysis. And again, you can see it's easier to see on this one. You've got that hypoechoic fluid there, which is the amniotic fluid, and the needle is coming there from the top left of that picture down, and you see that needle tip there, which is taking the fluid, and you've got the umbilical cord there, and the placenta is posterior. And as I've said, second trimester ultrasound, we can think about it as a screening test because we can pick up structural changes in the baby, so things like we've talked about, like anencephaly, thinking about omphalocele, those sorts of things, cardiac changes. So in some ways we can potentially think about it as a diagnostic test, not just as a screening test. Third trimester ultrasound, this is a busy slide, I apologise, but just the main points from this is that really once we get to that 84mm crown rump length I mentioned with that first trimester screening, we switch over into doing measurements differently. So then we start doing the normal measurements you would be familiar with on a third trimester ultrasound. So the biparietal diameter, head circumference, abdominal circumference, and femur length. And when we're talking about babies that are deviating from the norm, so we have babies that are small, babies that are large, we tend to use the 10th centile as our cutoff, thinking about that for babies that have low birth weight or have low weight, intrauterine weight. And then we're thinking about babies that are larger, then that's variably 90th to 95th centile when you're looking at the literature. Again, macrosomia, so thinking about a baby that's increased birth weight at term, you may have different cutoffs of 4 kilos or 4.5 kilos, but as you would know, our normal weight range, which used to be quoted at 2.5 to 3.5 kilos, is changing because of the habitus of women and the size of the babies that is having. So really up to 4 kilos is now really our normal birth range. The important thing thinking about third trimester ultrasound when you're doing it for growth purposes, then really we don't want to do them closer together than 2 weeks because otherwise we have an increased risk of false diagnosis of fetal growth restriction because of the error within the testing. So that's important because we don't want to cause an intervention for women unnecessarily. When you're thinking about doing the other parameters, so checking AFI or Doppler studies, then you can do those really every 48 hours if you would want to. And thinking about when you want to do a third trimester scan, if you're concerned about growth with your baby, then some studies have shown that doing that at 36 weeks is more likely to diagnose growth restriction than at 32 weeks, but obviously that depends on your clinical findings of fundal height and concern about fetal well-being as well. And then I just thought I'd put these on as well. So these are the Fetal Medicine Foundation, if you just Google the website, has a whole lot of free educational courses that you can do on different elements of ultrasound if you would like to do some education for yourself at home, which they do, I think, give you a certificate for as well, which would be useful for CPD. And equally, those ISUOG resources that I've used as guidelines at all different stages of the ultrasound as well, if you wanted to be able to do some reading from reliable sources. So that's the end. So I will stop sharing my screen.
Thank you so much. We do have some questions that have come through. There's a couple of lovely thank yous for the talk on iron, and a couple of people saying that you've taken their knowledge to another level. And a question was, when you refer to weeks of gestation in your talk, is it the gestational age based on LMP or ultrasound?
Yeah, so we're talking about well, obviously that is dependent. So it's a correlation between the two. When you have someone who comes in to see you and they say, I think I could be pregnant, at that point in time, you'll be giving them a gestational age based on what they think their LMP is. So they may come in and, you think, well, based on your LMP, I think that you're 5 weeks pregnant now. When they then go and have their ultrasound at that 6-week time, the ultrasound may differ with that. And we tend in those early ultrasound scans to take the ultrasound as what we would use for their estimated date of delivery, because there's less difference in that point in time with error when interpreting what the gestation is based on when we've looked at population studies. If someone comes in later, so they're coming in at 18 weeks of pregnancy, we'd still use that estimated date of delivery from the fetal size, but that is probably, there's up to 10 days error with doing that. So that is a conversation we would have with the patient saying, well, we've got your due date of delivery, but because we're doing it at this late stage, we didn't know what the genetic growth potential was of your baby. So we're basing it on what the median value is, but your baby may not be fitting precisely into that median value.
Okay, thank you. Is it likely that the NIPT will be Medicare funded? And there's a couple of comments saying that patients can't always afford the $400 for the test.
Yeah, I know, and it's a big barrier because that's the test that all women are talking about now and want to have. But obviously the cost is prohibitive, especially for women in the Central Coast LGA. I think there is discussion about that, and I think that one of the reasons that hasn't happened previously was because there was still concern about, is this more sensitive or specific translucency? But I think obviously as it's become standardized practice with increasing volume of women having that test, we can say we were actually quite as happy with sensitivity and specificity. So I'm hoping that that will be something that does change. But obviously, if a woman cannot afford that, then even though there isn't no cost in having a nuchal translucency, it is less cost. And equally, if there are women that are high risk, then you can get them to have their nuchal translucencies done through maternal fetal medicine units as well. And some private places may bulk bill for those tests.
Okay, and the final question that's come through is, what is the mechanism of constipation and GIT side effects from oral iron?
That's for me, I think. I don't know what the mechanism is. It's quite irritative to the gut. I have seen some patients who were on really high doses of oral iron, like 200 milligrams BD for long periods of time, who have actually developed a colitis, quite a severe colitis. So I don't know exactly what the mechanism is, but some sort of gut irritation.
Okay, and just a last chance, if anyone else has any final questions, if you could pop them in now. And I will remind you that we have the session next Wednesday night of medications in antenatal care. So that looks like it's it. We've covered everything. Thank you so much for your time. I hope everybody has a wonderful public holiday tomorrow. Rest up and enjoy the day. And yeah, we'll see you all next time and next week for medications and antenatal care. Thank you both for being with us, and thank you everyone for being here tonight. Good night.